indeed. We move now to paper 5, which is on, as I turn the page, Urgent and Emergency Care Review. I'm going to invite Bruce Keogh to introduce the paper for us.
Thank you, Chairman. We've been through this on several occasions, so I'll reiterate some of the key points and then take any questions. The paper starts by outlining the two principles that the Urgent and Emergency Care Review is trying to establish. The first is that we can get as much treatment as close to people's homes and in some cases in their homes as possible. And secondly, when people are suffering life-threatening or very severe conditions, that we get them to the right place where they get the most expert care. I'd like to, in brackets, add a kind of third principle in all of this, and that is that we need to join up the existing services in a way that they aren't at the moment, and we need to introduce a degree of simplicity, because there's a bit of an alphabet soup of names and things out there that I think can be quite confusing. The second point I'd like to make is that we now have established the footprints of 24 networks. We know that networks work. We know from the trauma networks on which these networks are based that in the first year of operation, despite ambulances carrying very, very, very sick people past certain A&E departments to get them to major trauma centers, that in the first year of operation for equivalent injuries we saw a 15% increase in survival. In the second year of operation, a 30% increase in survival. And the third year of operation, we're just a 50% increase in survival. So that gives us hope that the network model has got some credibility. We're doing a stock take of what's available in those networks in January, and that'll look at what services sit within in the network, what the commissioning arrangements are, and some more operational stuff like how many hours do you need for the case mix of patients that are in those areas and what facilities there are to provide the service. The third thing I'd like to say is that we've published guidance to help the system resilience groups, networks and associated partners understand what we're trying to achieve and understand how to develop a joined-up urgent and emergency care system. That's been supported with the publication on the 15th of October this year with commissioning guidance for integrated urgent care services. Subsequent to that, we advertised for vanguards for urgent and emergency care. We had 49 health economies applied. 8 were selected, 6 were local economies, and 2 were complete networks. And they are all developing their own local development plans, which we'll be looking at the end of November, or they'll be submitting at the end of November, and we'll be looking at in December. Sixthly, NHS England and Monitor have worked together to develop a more practical, simpler, and more logical payment approach to urgent care. And that's going to be tested in the vanguards over the coming year. The seventh point I'd like to make is that Health Education England are working enthusiastically, really, to see how we can review the sort of workforce that's needed to develop, to deliver a modern urgent care service. And we're really keen to promote the roles of other professionals in this. And you'll have heard me speak about that in the past, but we want to promote the role of physician associates. We want paramedics to be given the opportunity to do more treatment rather than simply transport people. We're keen to enhance the role of pharmacists. We believe they have a major role to play in the delivery of urgent care, particularly with certain types of ailments, and we think that they can take quite a lot of load off the accident and emergency departments, and we're keen to promote advanced clinical practitioners. So Health Education England are working with us on that. We're undertaking some financial modelling of the savings that a new service might bring, and that's underway at the moment. And you will see in the paper that we've also added as an annex a route map for our our direction of travel over the next year or so. And I'll stop there, Chairman. Thank you.
Thank you, Bruce, for the update. Let me invite comments and questions from members of the board. Noel.
So many of the things you described, Bruce, in the patient offer rely on a digital environment. The triage platform and the access to summary care records, and the many examples here suggest that a lot of this is going to be enabled by thinking quite differently about the digital world in which the NHS operates. How do you feel do you feel we're ready to bring this from some of our delivery partners in line with the delivery timetable that you have here?
Yes, I do. So there are two bits to that question, really. So you started by talking effectively about novel technologies. I think our starting position is just to use, frankly, the existing technologies which we have and join them up together in a way that they haven't been joined up before. And some of those will be quite simple things, like just ensuring that we have a decent registry of where every service is, so that when someone rings 111, they get pointed in the right direction. The second thing is, patients can reasonably expect that when they make a contact with the NHS, that we at least know something about them. And that becomes particularly important in an emergency situation. And so we've made very good progress on the summary care record, and we're making progress, increasing progress on who has access to that in a secure fashion. So those would be the sorts of examples that I would allude to.
Other observations, Margaret?
Terrific. I just have a couple of questions, if I may. The first is that the whole picture is a sum of lots of parts being properly integrated, and that integration is going to be key. And are you satisfied that we've got strong enough assurance, transboundary assurance, to oversee the functional links? That's the first question. And the second question is to do with the commissioning standards themselves. Splendid that we're establishing really clear standards. Just given the pressures of the system, a revision on an annual basis, is that something that you think is going to be easily accommodated?
So the first thing was about transboundary measures, and I think what you're really getting at is that can we be sure that all the parts are working in a way so that the sum of the parts is greater than might otherwise be. I think we can deduce that from existing measures, but I think your question is very well placed. I think we need to go away perhaps and do some thought to see whether we can get some aggregate measures which would help us, to understand that more quickly, but we inevitably need the existing granular measurements which we already use to understand which bits aren't working as well as others and which bits might be working better. Your second question?
The second question was about the fact that in order to keep the standards up,
so,
we want to review on an annual basis.
I think we've got to strike a balance there. So at one level, we're going somewhere we haven't been before. So you might quite reasonably expect us to change our commissioning models or update them relatively frequently in order to adapt for changing environments and new developments. And I think that's very reasonable, and we have the opportunity to do that. The other side of that coin is that increasingly in the health service, people feel frustrated that there's no stability in anything, and that we're always changing things. So one thing that we're quite proud of in the urgent and emergency care review is that absolutely everything we've done has been done in public. We did a little calculation which reckoned that for every paper we produced, over 2,000 people had a contribution to the authorship. So we will continue to do it in that way, so the changes that we might apply in the in any sort of guidance is drawn out of consensus from those people who are delivering and indeed receiving the service.
Moira.
Thanks, Malcolm, and this is very important stuff. Obviously, Bruce and has the potential to be a big improvement for citizens. I wanted to ask about Section 8, the independent care sector, and whether the work with the care homes vanguards is completely aligned with this, as it were, and in your risk register, no doubt, on the delivery of this, presumably this is flashing red, given the potential for reductions in care homes and domiciliary care that we've seen the sector talking about.
I don't have the risk register in front of me, but I think it ought to be flashing red for that. I think we've worked quite closely with the care home vanguards, but again, in the same way with Margaret, I'll take that away and just make sure that we are fully aligned. I think there's a lot of stuff going on, there are a lot of moving parts, and there is a risk at times that the cogs won't mesh quite as well as we like, so I appreciate those questions. Thank you.
Could I just add briefly, the UEC vanguards and the care home vanguards are all being overseen as part of an integrated new care models programme, and the support being provided for the UEC vanguards is part of a holistic package, so we are making those connections. We're still at relatively early days, given the timing around the selection of the UEC vanguards, but we're planning to do exactly what you're suggesting.
Thank you.
Right, well, Bruce, thank you very much for the report. I think it's been to the board several times before, and there's an enormously strong endorsement of the direction of travel. I think we all understand the sheer complexity of what we're trying to do, and your emphasis this morning on public participation in the process and clinical participation, I think, is also very important. But underlying that, and perhaps almost in contradiction to it, is a sense, can't we go faster? It's so much stress in the system lies around urgent and emergency care. One wonders whether the very high-level plans, and as moving into plans and then moving into execution, are going to deliver us the results with the urgency that we actually need in order to take stress off the rest of the system. Can you give us an assurance on that?
Again, this is a balance, Malcolm. So we started work, we recognised the emerging stresses in the system. We started work on the urgent and emergency care review early in 2013. We published the initial kind of findings towards the end of 2013. We've done now, I think, the basic building blocks. We've always been clear that this was not going to be quick, A, because it involves a cultural change for which we need to do the appropriate engagement. This needs to have been built by consensus from the people who deliver the service as well as people who receive it. And secondly, there are a whole bunch of technical issues which had to be addressed, many of which have been outlined in the in my presentation and in the route map. I think we do need now to beef up, if you like, the managerial component and support for that. So we'll be looking to do that over the next couple of months.
Okay, well, thank you very much. If there are no further comments from around the board table, may we note the direction of travel and, as always, give it our full support and endorsement as the board. Thank you, Bruce.